Hi, I'm Jack Cush, Executive Editor of RheumNow.com. It is the 30th of September 2016, and this is the RheumNow Week in Review. A number of interesting news items from our social media feed we'll start with. An interesting article looked at the microbiome of RA patients, but this time taking a look at the proteomics. And they found a number of interesting things, but one thing that stood out in my mind was that there was three different unique citrulline peptides in the proteomic profile of the gut microbiome in RA, and maybe lends the possibility that yet another source of ACPA and that antibodies that can react to citrullinated rich proteins may in fact originate in the gut. Heretofore we've thought a lot of that may come from the lung and maybe from the joints, but here maybe the gut is part of the problem. This goes along with a lot of the recent microbiome research. Artie Kavanaugh sent my way this interesting article about indomethacin treatment of cancer-prone mice, specifically looking at what happens when you inhibit PGE2. And what they did find was that in the mice that had these precancerous lesions, the use of indomethacin changed the cytokine profile, increased the cellularity with more CD8 positive T cells, and more gamma interferon production being done, all of which lended to a slowing of cancer progression in those mice. We've seen nonsteroidals affect cancer outcomes in many ways, presumably thought to inhibit COX-2 as one mediator, but it may just be that prostaglandins may have an important suppressive effect in some ways and stimulatory effect in others that can help cancer. So something to consider when we look at nonsteroidal use. An interesting report for presentation at a managed care meeting. Prime Therapeutics looked at the utility of Xeljanz in the community after its approval. The rate of growth of the Xeljanz drug has been slower than expected, but has been steady and going well. Interestingly, they showed that of all the uses of the drug, 10% of the use was in patients for whom the drug was not necessarily indicated, meaning it was being used before methotrexate and DMARDs and being used as monotherapy. A bit surprising. More surprising was the data that showed that at 1 year, 44% of patients were no longer taking Xeljanz, and at 6 months, 30% had dropped out. Again, is it the durability? Is it a safety issue? Is it just insurance? Who knows? But those dropout numbers are higher than expected. Research from Taiwan has looked at the occurrence of autoimmunity in patients with HIV. And they showed some of the things we might have expected, others we didn't. A higher risk of developing Sjogren's with an SIR of 1.64, psoriasis 2.05, lupus 2.6, autoimmune hemolytic anemia 35, uveitis 2.5. All of these have very wide confidence intervals, but suggest that patients who have HIV may be at risk for those disorders. As you may know, that there has been interesting research with tofacitinib Xeljanz in patients who have alopecia universalis, some really cool cases of patients with no hair getting full hair growth back by using high dose tofacitinib 10 milligrams BID. I have such a patient. It's really quite surprising. They've completed a study where they randomized patients to receive Xeljanz if they'd had either alopecia areata or alopecia universalis. A bit surprising was, I think, a lower rate of response than I might have expected. In the 66 patients, they showed that 32% met the standard of improvement, which is about 50% improvement in their hair situation. So this occurred at 3 months, so maybe with longer time, better results. And the doses used in that study were only 5 milligrams twice a day, and they might have done better had they used higher studies. There is a trial going on with alopecia universalis, and we'll await those results. IL-6 inhibition is not effective in lupus in a study that was recently published, headed by Dan Wallace and colleagues. Didn't matter what the outcome measure you looked at, an SRI-4 or BICLA, the results were not good. A recent review of scleroderma renal crisis reminds us that renal crisis occurs usually a few years after the onset of disease and is heralded by the acute brisk elevation of both the blood pressure and of the serum creatinine, along with oliguria, and half of the patients having thrombotic microangiopathy. Things to look at when your patients have scleroderma, especially widespread scleroderma. EGPA, heretofore previously known as Strauss, A study of 157 patients showed that there was a 12-year delay in the diagnosis of the condition, and that it was heralded by worsening of their asthma or the onset of severe asthma. So those are things that one might look for as diagnostic clues. Rates of septic arthritis have been increasing steadily in the last 15 years. A study from out of the UK showed that the increase has been 43%, in fact, and that this is especially problematic in the elderly, meaning those over the age of 75. Infectious events in RA are not uncommon. A recent report shows us that it's clearly related to disease activity, more so than therapy. The risk with biologics, when it does occur, is most likely to be in the first 6 months of use. An analysis of RA patients and the prescriptions they receive is quite interesting. This report looked at RA patients, compared those to non-RA patients, and what kind of prescriptions are they receiving. And they showed that RA patients in general get more prescriptions than do non-RA patients. And of the drugs that they get, they happen to be GI drugs, antibiotics, thyroid drugs, tricyclic antidepressants, asthma, and other inhalation therapies, including inhaled steroids. PPIs and antihypertensive drugs lead the way. All this suggests that comorbidity is probably a much more significant problem than we give note to in our patients with RA. Another study looked at, are we using immunosuppressives with any hope in patients with scleroderma? A small report looked at 5 patients who had scleroderma who underwent transplantation and received multiple powerful immunosuppressants, and they did show that there was an improvement in skin and lung function in those individuals. So very interesting reports. In feature articles we published today, that nonsteroidals pose a significant and dose-related risk for hospitalization with heart failure. This is a report from the British Medical Journal that looks at 27 nonsteroidals, including 4 COX-2 selectives, and it showed that 7 are specifically associated with a higher risk. It does include naproxen with the lowest 16% increased risk versus I think it was ketorolac that had an 83% risk. But interestingly, again, one, it was dose related, higher dose was associated with a doubling of the risk, and that it wasn't seen with celecoxib, and that may be because celecoxib dosing tends to be lower, 100 or 200 milligrams once a day, but nonetheless, there wasn't the same results seen with celecoxib. The anti-sclerostin drug, romosozumab, or if you say it like it's a very interesting drug with the name, you should say it like a romosozumab, and then bow as if you're visiting Japan. But the anti-sclerostin drug, a bone hardening drug, is again shown to be effective in women who are at risk for fractures, postmenopausal women with, I think, T-scores greater than 2.5 and up to 3.5, and they showed that there was a significant reduction in the number of new vertebral fractures in the romosozumab group compared to those on placebo. However, that there wasn't a significant reduction in the group as far as non-vertebral fractures. About 2% were seen in those. So sort of some expected, some unexpected findings. Where this drug will fit in the our therapeutic arsenal in the future remains to be seen. I'll end with 3 large announcements from the FDA, 3 new FDA approvals. The FDA approved a new biosimilar. It is the Amgen version of adalimumab. They call it Amjevita, also generically called adalimumab-ATTO. Adalimumab Ado, as in Ado, way to go, boy. I'm not sure. So again, when you get these new biosimilars, they're going to add a suffix to them, and then also add a suffix to the originator drug. This becomes the 4th biosimilar approved by the FDA, the 3rd TNF biosimilar approved this year. Interestingly, all 3 new TNF biosimilars were approved 8 to 10 weeks after the recommendation of the Arthritis Advisory Committee, and they are approved for the same indications as is the parent drug. In this case, all the adalimumab indications, with the exception of some of the newer ones like hidradenitis suppurativa and uveitis, probably will not get the same because they went through different pathways. The FDA has also approved ustekinumab or Stelara for use in patients with moderate to severe Crohn's disease based on 3 Unity trials, including those are the names of the trials, including use of ustekinumab in patients with just failed DMARDs and those who failed TNF inhibitors. And they showed a higher percentage of patients treated with ustekinumab achieving remission when that was added. And those were patients, including patients who had previously been treated with TNF inhibitors. As you may remember, that last year at the ACR, already Kavanaugh presented the data of ustekinumab and ankylosing spondylitis. That is not yet FDA approved, but that is going forward in other trials. So keep your eye on ustekinumab. Again, it's IL-12, 23 inhibition. It's a lot like IL-17 inhibition. Th17 axis is being affected and manipulated by these therapies. And lastly, Ilaris or canakinumab has received FDA approval for 3 autoinflammatory syndromes: the TRAPS syndrome, the hyper IgD syndrome, and familial Mediterranean fever. Previously, Ilaris was approved for use in CAPS, the cryopyrin-associated periodic syndromes, and those with systemic onset juvenile arthritis over the age of 2, and that includes not just kids, but also adults. These are significant advances from the FDA this week and significant advances posted on RheumNow.com. Tune in, go to the website if you'd like to get the links and read more about these particular citations in this video and audio. You can follow us on audio as well as on video by going to iTunes and downloading the podcast. Thanks very much. We'll see you next week with more news from RheumNow.com.